It is just a huge honor for me today to be podcast interviewing Dr. Dennis Edward Brown, DDS, who's been practicing dentistry for 43 years. He's a Vietnam veteran. Thank you for serving our country, Dennis. After leaving the Army, he attended the Ohio State University, receiving his DDS degree in 1977. Dr. Brown opened a private practice in his hometown of Owensville, Ohio in October 1978. Dr. Brown combined his practice with Cincinnati Dental Services in 2018. He is also the founder and owner of Greater Curve. The unique curvature of the Greater Curve Matrix band provides dentists the ability to restore both anterior and posterior teeth with predictable, tight anatomical contacts. The Greater Curve Matrix isolates well throughout the bonding procedure, and dentists can restore difficult multi-cusp composite restorations. I've been wanting to get you on for so long. He has a course on Dental Town. Dental Town Learning Online presents Simplified Composites by Dennis Brown, owner of Greater Curve Toffelmeyer bands. That's AGD number is 250. The course is, everyone's given it 5 stars. But before we get into this podcast, Dennis, I know you're from Ohio, and so was my beloved, both of us had a friend, Sally Mckenzie, who passed away yesterday at the age of 69. R.I.P. to Sally Mckenzie, 1951 to 2020. I just want to read her obituary. Do you mind if I read her obit?
I knew Sally. That's sad to hear.
Oh, my gosh. Sally Mckenzie, the founder of Mckenzie Management and a leader in the nation's dental practice management field, passed away unexpectedly on September 1st at her home. She had moved from Ohio and retired in Tarpon Springs, Florida. She leaves a void that will not be easily filled, as Sally dedicated her career more than 50 years in dentistry to improving the profession and advancing the cause of women as owners of dental businesses. For more than a decade, Sally was the publisher of The New Dentist, opening the door so that countless young dentists could be heard. Born in Barnesville, Ohio, to a mother who worked as a dental assistant, Sally began working for a dental office at age 16. 2 days after her high school graduation, she began her first career as a dental assistant. At age 25, she taught dental assisting at a vocational program in the public schools of Columbus, Ohio. By age 30, she started her first business, an employment agency for women dental professionals. Her true business passion, her second business, Mckenzie Management, spanned more than 30 years and thousands of dental offices, including mine. She helped to advance in personal management and profitability. She was the first consultant I hired back in like 87. A true task master who frequently described her business with, "This is my special sauce. We can do better." Sally was known to be a hard bargaining negotiator who would remind her adversaries, "Your word is all you have in life." She spoke frequently of the lessons she learned from the friends she counted as her trusted mentors in business: Phil Bonner, Howard Ferran, Bet Johnson, and Hugh Dougherty. As Bet Johnson said of Sally, "I will be forever grateful I got more than a glimpse of a powerful woman who pulled herself up from nothing to become everything." She was a life force. When Sally entered a room, there was no question a woman worth meeting had arrived. Sally's career can best be summed up in her own words, taken from letters she wrote rejecting an offer to sell control of her business. "After careful review, consideration, and paying attention to my gut, I am respectfully declining the proposal on one important premise. I am an independent-minded businesswoman. This is what made me successful. This is what makes me the happiest." Sally Mckenzie leaves her beloved Tom Bennett, her niece Tara, and countless admirers who live and careers in dentistry she helped to save. We were fortunate enough to podcast interview her just a month ago. Sally Mckenzie, running a dental office during a pandemic, was episode 1414. But long live Sally Mckenzie. God dang, I love her. And she'd be mad at me if I was sad. She would. She would just sit there and say, she had a great life. We should be celebrating her life. When I was little, it was confusing because my pedigree's all Irish. And so we go to Wichita to Parsons, Kansas. And when an Irish wake, see, they were Irish Catholics. So they thought all the Protestants cried at funerals because they didn't really believe. But the Irish, they believed. So it was like a 3-day drunken fest. And you had to stand up and say the most embarrassing moments, and and it was just, they were all celebrating that this person's in heaven, and they were still stuck down here on earth. But God, she, how did you know her? You were in Ohio. Tell me what you knew.
I had met Sally several times at seminars. And I way back then, way back in the 80s, I may have attended a seminar that she had given. So, but I never have had her in my office as a consultant. I never had her.
My gosh, it was when I got out there, I knew I wasn't going to spend my whole life reinventing the wheel. I first wanted to know what everyone knew about the wheel. So I started bringing in dental consultants. She was the first one. And to this day, 30 years later, I still hear people say, like in my team, well, Sally wouldn't agree with that. Oh my gosh, she was great. Thank you so much for coming on the show. And my God, on Dental Town, you are, really, you're beyond a legend. You have, my gosh, you not only do you have 2,000 posts on Dental Town, they're not a post. One thing about counting posts is a lot of posts like, I agree or I disagree or no way or whatever, But your posts are always cases with photos and showing technique. I mean, those 1,823 posts from 2002 to 2020, 18 years. So you're doing about 100 posts a year. Gosh darn, thank you so much. You've educated so many dentists, especially with your online CE course on Dental Town. I got to start off with, they say necessity is the mother of invention. What the hell went wrong with your first Class 2 composite that made you start the greatest Class 2 composite Toffelmeyer company in dentistry today?
Well, first of all, I want to thank you for Dental Town. I mean, to me, it's a great place to hang out. And, the imagination it took you to have the concept and learn the skills, whatever you needed to do to make it happen, I'm very appreciative. So,
well, let's start the Mutual Admiration Club, and it'll only be 2 members, just me and you, and we'll just meet up, and I'll bring the Jameson. So what went wrong? Your first Class 2 composite, I assume the patient died. I mean, to start a whole Fortune 500 company, the greater curve after this thing, I imagine you're still suffering post-traumatic stress disorder from your first Class 2 composite.
Well, here's the scoop. I started doing Class 2s, and there'll be times where you have a contact, but it's a little white. And so now you got this dilemma: is that good enough? And then what do? You look, well, where am I in the world? You look at the schedule, and so the hygienist needs you. You're backed up 10 minutes, so then you get the floss out, and you try that contact again. Then damp it, then get a little bit tighter. So I hated to be in that position, and so I thought that there's got to be a way to have Class 2s be more predictable. I don't mean that this happened to me every day, but there'd be times where it just you'd be caught. And you go, why didn't that work? So I started looking, what's causing the problem? And basically, we restore teeth as far as Class 2s. We kind of just borrowing the old amalgam system where we're trying to wedge and separate teeth apart. And for amalgam, that seemed to work pretty well. And it's something that's been reliable. Well, for composites, it doesn't always work. And what we have now is our sectional matrices, and that seems to be the most popular way to restore Class 2s. But there were some problems there. Some teeth just do not give. Periodontal ligament just tight, and no matter how much you try to wedge or place your spring, the tooth does not give. So once you remove the matrix, you got a light contact. Teeth got wide embrasures. I'm not sure what a wide embrasure is, but some, where the composite needs to travel a little bit further than a normal Class 2 composite. So it's difficult to get the composite to extend to the contiguous tooth contact and still have a tight contact. And there's teeth with deep root decay. So there you need to seal the tooth. It's subgingival. You're trying to seal out the contaminants, and still maintain a tight contact. And teeth with deep root decay very often have wide embrasures as well. So, I saw that was a problem where my sexual matrix was not always, there for me. Um, Teeth with short clinical crowns, little tiny, maybe a tiny tooth, but some teeth are just not tall. So the time you put in the wedge and all the hardware you needed to separate the teeth, the contact would be very occlusal, and because there just wasn't enough room for everything. And short teeth, the whole sectional spring tends to pop off. So, I found that I had problems getting good contacts on shorter teeth. And then you got MODs. With MODs, you're placing your wedge to the mesial and you're forcing the tooth distally. And then you replace your wedge and your sectional spring at the distal of the tooth. And now you're forcing the tooth medially. And it's like the tooth says, what do you want me to do here? You're forcing me back and forth. So what do you end up? You end up, very often with a light contact with an MOD. The other side's tight, the other side light. So these are the things that I realized that my sexual matrices were not doing it for me. So I started to think, I had this greater curve band that I just used for class 5s, and I just had it for me. I had a high school student, she'd come in and make them up for me. And I called them Laura bands because her name was Laura. But in any event, she would make these bands and I use them for class 5s. And one day I said, well, let's just try a class 2 with this greater curve band that I had. And I thought, well, what if I just put a little hole right where the contact is? And no wedge needed. Therefore, I'm just building the tooth in a neutral position. And because I know going composite directly on anterior teeth worked great, because I'd done it for quite some time. So let's see if it works on the posterior teeth. So after I made the little openings, well, actually, what I do is I scratched where I wanted the hole to be, took the band off, made the hole, put it back on, and then my composite, lo and behold, I had good contacts, mesial and distal on this MOD. I said, well, maybe I got something here. So that's basically what I'm doing is I'm building teeth with the greater curve system in a neutral position. I'm not worried about wedging and trying to establish contacts in that manner.
You said so many profound things. I don't know even where to start, but let's start. I always, old guys like us should be trying to transfer our knowledge to our replacements, and the technical stuff's easy. It's the mental stuff that's hard. And so I want to get your experience. I mean, how many posterior composites have you done in your lifetime? I'm thinking 10,000.
I guess you're right. I mean,
I don't know.
77, so and that class 2 composites or composites anteriorly, posteriorly, that's the lifeblood of dentistry now.
Well, if you work 40 hours a week, 50 weeks a year, that's 2,000 hours. If you did 1 an hour, how many do you think you did a day?
Oh, generally you do at least 4 or 5 anyway. I was in a rural practice, so I was working extractions as well.
So, it's hard to wrap your mind around these judgment calls. And so I want to go back to, you said you did a class 2 matrix. The contact wasn't that tight. You're running late. The hygienist is waiting on an exam. And how should a quarter of our viewers are still in dental kindergarten school, and the rest are all under 30. Everybody sends me an email, howard@dentaltown.com, or puts a comment in the YouTube deal. They're babies. And so the patients, you just finish this thing, you go to floss, and it's just not quite like you like it, but you're running late. The hygienist is waiting on exam. The patient isn't paying for it 6 out of 10 times. They're on some volume insurance plan where you might be losing money or breaking even or making minimum wage. What makes you? Does the patient have anything to do with your decision of redoing? Like if it was a dentist in your chair, you'd obviously redo it. If it was someone who's really into their teeth and takes care of their teeth and all that, you do it. But what about, it's the same thing with having other people pay for your health care. Like say you need a $50,000 knee replacement. The 20 countries will replace it for you for free of charge without any copayment. And I've always said, well, if there should be a 10% copayment on all healthcare because it makes the patient make a better decision. Does this patient have skin in the game? I mean, if you're getting a $50,000 free knee replacement from Medicare, you should come up with $5,000. And if you say, and when you say that, half of them say, "Oh hell no, I'm not paying $5,000. I'm going to go eat my bufferin." Well, then why should my taxes pick up 50 if you don't care? And same thing on teeth. Are you a bad person if you're sitting there thinking, okay, look, this guy, he hasn't had his teeth cleaned in 5 years. He doesn't floss. He doesn't brush. He doesn't care. And good, do you think good enough is good enough for people who don't have any skin in the game versus good enough is not good enough? It needs to be great if the patient has a lot of great skin in the game and they really care, like, your patient's a hygienist, a dental assistant, or is a yoga instructor and only eats kale. I mean, do you do that or do you not, or does that not ever play into your psychology?
Well, obviously, you try not to have that play in your psychology.
But do you believe that though?
If I'm in the moment, I honestly don't think of all that. If I feel like this has got to be redone, it's got to be redone. I just bite the bullet and do so.
Well, yeah. If it has to be redone, but I'm talking about the judgment. I'm talking about the gray zone.
It's going to be good enough, and then you look at the person as this is a person I see pretty reliably, at least once a year. That's a person I may let go because when they come to hygiene, I'll be able to follow up. And if it just being a food and packaging site, then we're going to redo it. But my main point was, I just hated when I was in that position, so I want to do something more predictable, so I would never have to not be in that position in the future. That was my goal.
And so you're a dentist, and the thing I like about dentists is, dentists and podiatrists and veterinarians and chiropractors, they always own their own business. So many physicians don't have any business in the game. They're all employees at hospitals and things like that. So you already had the business skills of running your dental office. Did you see the vision of Greater Curve? I mean, how early on did you realize this was going to turn into a serious business that helped dentists from Kathmandu to Kansas to Australia? I mean, you have another, the V Dental Australia, vdental.com.au. Is that your company or?
No, actually, I'm a supplier of my bands for that particular company.
Yeah, because I know I lecture down under every 5 years, and they were huge fans of yours for years.
I'm a wholesaler for V Dental, so, and I have a number of distributors overseas.
But how many years did you own your own dental business before you started Greater Curve? And
I started my own dental business in like 78, 79. In Greater Curve, I started in 06. It was 06 when I started Greater Curve. And and Greater Curve got its start on Dental Town. That's where I launched. So, I put together a little website. It was a terrible website, but, I got it together and I was able to take orders, put it on Dental Town. And I tell you, that first night, it was incredible because I put a few cases up. And actually, Bruce LeBlanc was, he's been on Dental Town quite a bit. He's the one that put the first case up because he
was it?
Very happy with my bands. And
who did you say it was? Bruce LeBlanc?
Bruce LeBlanc is in down in Louisiana.
Oh, Bruce LeBlanc, yeah, in Louisiana, absolutely.
So he posted, so I said, I'm ready to go. I got my website, I'm ready to take orders. Put a case up, Bruce. So Bruce puts the case up, and boy, the clicks started hitting that case. And then, by this time I had a good library of cases, so I just started putting them on Dental Town. it was fun that first night. It was just a ball. Because because it was a different concept. People had never seen anything like, well, first of all, making an opening in the band directly intraoral was like foreign to dentists. It's like, you can't do that. I mean, I got pushback. You said you can't do that. That interproximal enamel is sacred. You can't adjust that. And I'm thinking, that's ridiculous. We adjust working contacts. We work just balancing contacts. We adjust teeth for frameworks, metal frameworks. So what's so precious about this interproximal enamel? So, and especially when I make the little opening, I use a composite burr. It's a little tiny football one, and it's just a side-to-side motion, very gradual. I'm just barely sweeping away the matrix, the stainless, and just barely exposing the contact. And what do I get? Well, what I do is get a contact that's got both width and a contact that's got depth. So what I'm actually doing is mirror imaging the contact of the adjacent tooth. So I'm taking full advantage of that surface.
And what I also love about what you could do with Dental Town is starting that company, posting on that is you're connected with your customer. So you're getting feedback. So you're posting a case. So you're marketing, but you're connected. So if somebody doesn't like something or wants feedback, I mean, it's all connected. I mean, it's just perfect when a supplier and the people demanding the supply and demand equation is all connected. Did you feel that Bruce LeBlanc out of LSU in Louisiana, did you feel his feedback or did you feel that his or other townies' feedback, did it change anything that you were doing?
No, not really. I mean, I had a number of dentists using my little matrix before I put it out there, because obviously when you start something like this, you want to make certain it works. So I wanted enough dentists out there that thought the product was worthy of investing money further into it. And so that's how I got started with it. And then of course I put it on Dental Town. It really took off, but the concept really hasn't changed since the day I put it up in 06. We have a brass band now, which is kind of nice because it's more malleable and you can burnish in emergence contours better than the stainless. So the stainless and the brass, they each have their advantage. But as far as making any real changes, that was the only change I really made. It's just a material change with the brass.
So do you sell these all through distributors or do you sell direct?
Right now, it's all direct. Our distributors are overseas, but as far as USA, it's all direct.
So talk about that, because it's been an amazing 32-year journey. I mean, I remember having dinner with John Miles in Chicago at the airport Hilton, and he was telling me that the distributors mark stuff up, 38, 40%. And then he's competing against companies that sell direct like Ultradent and Denmat and things like that. And he said, I don't understand it. He says, I got 1,000 reps in the field, but all the orders go through Patterson, Shine, Benko, Burkhardt. And then, they mark everything up. And then when I just get a list of my sales, I don't get a list of the actual purchasers of who bought what. And now Dentsply Sirona, you'll notice the newer companies like Tulsa Dental, their endodontic division from Ben Johnson, that sells direct. Talk about the decision, because a lot of people are seduced with, well, my God, I mean, I have instant distribution if I go through a distributor. Kind of like you can have the greatest product in the world, but with no marketing, you don't sell any. But if you got Walmart to carry it on their 4,000 stores, where 92% of Americans are within an hour drive, but it costs a lot of money. So what was what made you go direct instead of through distributor?
Well, I like control. I just want the control. I don't feel a need to go direct. I feel like the word's getting out there, but I don't need to have distributors. Obviously, I use the overseas distributor just because it's a way to get into that market. But as far as USA is concerned, I think most people now are pretty starting to get familiar with the greater curve, so I don't really see a need to have a distribution channel in the USA.
All right. But did you ever shop it around? I mean, did you ever see what the cost would be if you went through, say, Benco or Shine?
I mean, I can say I did look at it, but I said, just, I stay in direct, I keep my costs down, or I keep the cost down to my customers. And so,
And so what is the cost right now?
well, a package of 100 is $54. Yes.
So $54 for a pack of
Yeah, which is very similar to, a central matrix, little tiny band. It's basically the same cost as using one of those.
Well, let's talk about the technicals, because a lot of times, young dentists, they're going to work as an associate in somebody's office, and the assistant just has bands there, and they might not even know all the different names. If they go to your website, greatercurve.com, you show a standard band, a wide brass, and a U band. Why do you have 3 types of bands?
All right. I guess each band has a different usage. You basically have a standard band, a wide band, and a U band, and then they all come in stainless, and then they all come in a brass version. And so, the workhorse is the standard greater curve stainless steel band. The wide band is great if you got like tall teeth or anterior teeth. So, actually I use a Koffelmeyer for anterior teeth, which might seem unusual to folks, but boy, can I get a seal and boy, I have control of the emergence contour. So, with a Mylar strip or a wood wedge, you get black triangles, you don't get the seal. So the greater curve matrix works beautifully for anterior teeth. So you got the wide band for taller teeth, and then the U band, just a band each actually has a more exaggerated arc, and that's really good for class 5s because you can slip that down over the teeth and pass the margin and get the, especially if you've got a subgingival class 5, you get that gingiva out of the way. And one unique thing about the greater curve is it just happens to be, not that I planned it that way, but when you crank down on the greater curve band, because of its exaggerated arc, it pulls in very tight around the cervical part of the tooth, so you get a beautiful seal as well. So now you got a circumferential seal around the tooth. So I mean, I can go further now. So your U band is good for, let's say you've got a real wide embrasure, the U band. See, one thing about the greater curve is a standard band, a standard Koffelmeyer band, the traditional been in dentistry forever. When you crank down on it, it collapses into the tooth. With the greater curve, when you tighten it, it actually flares out and goes up against the adjacent teeth. And that's the advantage of a greater curve over a standard matrix band. So now we come back to the advantage of the stainless is it's very stiff. The disadvantage of the stainless band is it's stiff. So when you place it over a tooth, let's say you got a DO and the mesial part is still very tight. Well, a brass band is going to collapse. So you want to go with a stainless. You got an MOD, you might want to go with the brass because it's very malleable and it can easily place around an MOD, and then you can burnish in your contours as needed. And it's very easy to make a contact opening. So brass works really well for like an MOD. And for anterior teeth, brass is very pliable and it works beautifully for the brass version, brass version wide because most anterior teeth are tall. It's a 9mm width in the middle. The brass works beautifully for anterior teeth. So you have to look at the situation, the restorative requirements, and you pick the band that meets the ability to do what you want.
So the original Koffelmeyer matrix bands were designed for amalgams, though, right?
No, not really. I mean,
not really.
But the original, they were just for. I designed it for composites because, again, if you put a standard.
No, I'm talking about the Toffelmeyer. The generic word Toffelmeyer matrix band, not yours from Greater Curve.
For amalgam, yeah, because with amalgam, you can put that standard band on. You can condense your amalgam, and it will force the band to go up against the adjacent tooth, and it stays there. Composite, you don't have that luxury. The band overcomes the composite, and so when you come to do a composite, you got to make certain your matrix forms a composite. So that's where the greater curve, it flares out against the adjacent tooth, so it's up against the adjacent teeth to begin with. Now you can use the greater curve for amalgams very, very, very well. I mean, especially if you got large embrasure space.
So I want to go over your starter kit just because I want to see why it has what it has. So your product starter kit, how much is your product starter kit?
We have two versions. One is for 120 and the other is 295. And basically, there's a retainer in the starter kit, and the 295, the larger kit, has two retainers. My retainers that I modify or make for greater curve, they're designed so you can crank down on the band more tightly without it breaking. Also, the little vice portion of the band, I open that groove up a little bit so the band slips in a lot easier. It's a lot easier to get the band in within the retainer quicker. So I do some modifications on my retainers. And I've been getting a lot of good feedback on my retainers as well.
So the starter kit, you started with 96 standard, 48 micro thin, 48 wide, 48 micro wide, 48 U bands, 48 micro U bands. And I imagine if you were in dental school and you haven't done 10 class 2 composites, you're still probably trying to wonder why sometimes you need a micro thin, a micro wide, why do you need a micro as opposed to a standard?
All right. First of all, personally, I do not use the micro thin. I had dentists who wanted them, so I put it out there for them. But since I make contact openings through the matrix, it doesn't matter how thick the material is. So I find this different material is easier to manipulate and work with. But some dentists still do not want to put in a little contact opening. That's fine with me. The micro thin is going to work better for them. So that's why I came out with the micro thin version.
Oh, when I was asking about the Toffelmeyer, I was talking about the invention. Do you know who invented that thing, the Toffelmeyer?
It was Dr. Toffelmeyer back in 45.
Yeah, it was Benjamin Franklin Toffelmeyer.
Yeah,
and that was from 1896 to 1963. Yeah. Wow, that is just amazing. How cool is that? So what do you? So let's say you're a student. You haven't done 10. You've done 10,000. I think it's the hardest part of the composite. I mean, at their stage of the game, it's probably missing a lower block, getting anesthesia, maybe patient skills, talking to the patient. But what do you think a young student should think about when they're doing these composites and contacts? That you picked up over 40 years, that, how could we make them pick up what you know faster?
Wow. I can tell you this, on my website, maybe I have too many cases, but you go on my website and you can pick what you want to do, whether it be a class 5, class 2, build-ups with a occlusal stamp technique. I have tons of cases on my website. So anybody who want to be educated on how I do dentistry or composite dentistry, it's all there on the Greater Curve website. It'd be the clinical, what is it? Clinical tips. There's a link that says clinical tips, and there's tons of cases.
Yes, there is amazing cases, and you got YouTube videos on it, and all kinds of stuff. When you started your career, were you also doing posterior amalgams?
Oh, yeah. Yeah, I mean, I didn't do composites when I started my career in '78, as far as
And
posterior.
and when we started doing composites back in the day, they weren't very good, were they?
No, no. I mean, I stayed away from them for the longest time.
Oh my God! When I graduated in '87, Dr. Moore, in charge of the UMKC operative department, gave each one of us a deal to sign, an ethics pledge to restorative dentistry, that we would not do the newfangled composite junk, and we would stick to amalgam fillings and gold restorations, and PFMs was the new thing. And I mean, it's just come a long way. But my question is, the only thing new in life is the history we haven't learned. Do you think the composite, class 2 composites that we've replaced the amalgam with today, the ones we're doing today, 2020, or let's say 2000 to 2020, how long do they last compared to the amalgams we were doing in the 80s, would you say?
Well, I think, the thing about, composites is meticulous detail. If you follow, you just have to be very meticulous about how you place them. But I think they have some, tremendous advantage, especially now with the more bioactive composites that are becoming available. If you place a composite, like I said, with being very meticulous about how you do the work, I mean, I think it's going to last as long as an amalgam. In fact, I think, let's say this. Let's say you have a very conservative occlusal amalgam or a very conservative class 2, amalgam is probably going to hold up pretty well. But if you have a large buildup, and you want to do it in composite, I think a well-done composite that's multi-cusp, I think that's going to last longer than the amalgam if it's done correctly. Because I got a ton of them out there that I did 10 years ago that come back look as good as the day I placed them. Might be a little wear, but boy, they're sealed.
So why do you think every dentist answers just like you do? I mean, every dentist just answers that question verbatim, in my hands, in Mr. Magic, but it just doesn't show up in the insurance data or the research. I mean, you can't go to PubMed or to your friends in the insurance company looking at millions of claims and ever come. I mean, basically, the macro data looks like the posterior composites are about 6.5 years, and that's being kind to them. And the amalgams are 38. I mean, one's metal. It's, they fail from biology, recurrent decay, and the metal one is half mercury. I mean, they don't put that in the multivitamin. The other half, silver. That's silver diamine fluoride antibacterial. You got 10. Stannous fluoride is 10. I mean, the amalgam's metal, and it's all toxic, anti-life stuff in the biosphere. And the other one's an inert plastic. So, it's like saying the plastic fork at KFC lasts longer than the metal one in your kitchen drawer.
Well, again, it just comes back to if you're very meticulous about how you place a composite, it's going to hold up well. I mean, it just is. But it's easy to get
I do think the Holy Grail. I mean, I've been talking to those CEOs for my whole career, and I remember sitting down with Bob Ganley. I said, Bob, your Ivoclar composites are inert, and they're replacing a massively antibacterial amalgam. And he says, I know, Howard, I know. The Holy Grail is to make, he says, there's 30,000 chemicals that are antibacterial. And he says, we're scouring them, and that's the Holy Grail, is to make a composite that's actually antibacterial.
Well, that'd be great. The
other one he wanted.
I'm no science guy. I mean, I just find a material that works for me, and I'm just the good clinical. I try to be the best clinical dentist that I can be. And when you start talking about materials and all that sort of thing, I can't help you.
But because where I was trying to go with this is to the young kids, is that we started with doing amalgams with Benjamin Franklin Toffelmeyer. And so when you started doing posterior composites, you were using an amalgam Toffelmeyer from the century before. And so what I want to do is how was the traditional Toffelmeyer failing you to make you want to start this whole new one? What was wrong with the Benjamin Franklin? I mean, was
Because
it his name?
when you tighten it, it collapses in against the tooth. And so composite is very dependent on the matrix. Amalgam, you can force the amalgam in there and it's going to stretch the matrix. You can actually loosen it up a little bit, allow the amalgam to stretch. You can open up the matrix a little bit, pack in your amalgam, and it's going to maintain its shape. When you do a composite, you can't do that. It's too plastic. So the matrix has to be perfect, and for the composite to fit the tooth or to be the way you want it. So that's when I came up with the greater curve system, because when you tighten that band, it spreads out against the adjacent teeth.
Okay. And so did it fail you a little? I mean, did you do you think, I mean, how many years did you do posterior composites with Benjamin Franklin Telfameyer's amalgam Telfameyer before you had greater curve?
Actually, I went to sectional matrices before I did any kind of composites with a Telfameyer.
Okay,
Now,
so you went from the Telfameyer to sectional matrix.
Yeah, so now that was the old system where you had a very simple ring. I never used the more sophisticated sectional matrices out there now. Ones with the, I mean, I just never used them because by that time I was working very well with my greater curve system. So I never felt a need to go to a sectional matrix.
Huh? That was yeah, that was it's been a long journey on composites, and then they were sensitive. The bonding agent was sensitive, and the only one that listened to the clinicians. Remember back then when posterior composites were getting good? Everybody on Dental Town, if you did 100, you had some sensitivity.
Right.
What was your sensitivity like with posterior composites in the 80s versus the 90s versus the 2000s versus the 2010 to this day? So. What year do you think you did your first posterior composite?
Oh, gee, I don't know.
I mean, did you do them in school? You graduated from the Ohio State in '77. Did you do any?
I stopped using amalgam, I say, in mid-90s, maybe. I would say that's probably when I quit using amalgam, because that's when I started becoming very comfortable with composite. And by that time, the bonding agents were good enough that, again, if you really follow the instructions carefully, it had very clean preps. I never really had a lot of sensitivity problems, even back then.
So sensitivity was never a problem for you?
No, I mean, I can't say it never, but I can't say it was a day in, day out. There's never really a problem, no.
So what bonding agent are you using now?
Right now, I'd be honest with you, I haven't been in the office since March, since the COVID thing hit. So
right, but I mean your last 1,000 fillings.
I I'm trying to think about bonding agent that I used.
What composite?
Oh, I love the Activa. Now I like Activa for a base. If it's a very conservative restoration, I'll use Activa all the way to the gruel surface. But if it's a larger composite, I'll use Activa as a base, and then I would place a more conventional hybrid on top of that.
I think this is a good question to go to, because you picked Activa, which is what I was talking about earlier, an active ingredient. And, of course, Activa is a bioactive composite from Pulp Dent, and that's kind of Pulp Dent's things. And they have a ton of fans on Dental Town, no doubt about it. Do you think the Activa bioactive restorative composite is really a measurable thing? I mean, do you think it's the journey towards a bioactive posterior composite that will help defense against all the things in biology, from archaea to eukaryotes to prokaryotes to fungi. I was amazed last year when I never saw it coming, when that research paper came out that said that fungi was a absolute crucial component in forming a decay. The fungi had to work with the Streptococcus mutans to form a barrier around it, and they were working together, and the fungus was to block everything around it. So, I mean, it's just it would be so cool to come back in 5,000 years to find out what what was all going on. But do you think pulp dent, they're on the right track? Everybody knows you need something bioactive in the biosphere. Do you think it's the first to journey into bioactive, and do you think it's measurable and real as of today?
Well, again, how bioactive it is, I think it's certainly more bioactive than a normal composite or the standard composite we've been working with for quite some time. I trust it enough that, if I'm doing a crown and I got a very deep subgingival prep, I'll place the Activa in the base, and then I'll prep on the Activa. In other words, the Activa, then I'll be prepping on to structure as far as the margins are concerned, and Activa both. Because I would have a very smooth, well-sealed composite, deep subgingival, than some crown margin way subgingival. I find that when you do that, you can even violate the biological width, and the gingiva does just fine. And I do this all the time with the anterior teeth. You place a well-sealed, I'll use Activa base on anterior teeth, and then put a conventional composite on top of it if I want to. But I think if you have a well-sealed composite subgingival, leave it. Prep your crowns. And don't try to get down on 2 structure 360. I think you're better off prepping super gingival if you can, and have a composite margin. I mean, let's face it. If you cement a crown with a composite cement, what's your margin? It's composite.
Composite.
Anyway, so if you're confident you got a well-sealed composite, you've got the field really dry and not dry, but you got it sealed off so there's no contaminants, and you place an Activa in there, I would have the Activa at the subgingival area than a crown margin.
I cannot tell you how much I loved in the 80s using those copper bands. I mean, I was always, when I needed dry, we take those soft copper bands and cram it around the tooth, which leads to my next question for these kids. The greater curve is just, you got to try the starter kit. This is no commercial. Dennis, did you give me any money to come on the show today?
Okay, we'll talk about that.
No, I said, did you? You didn't. But you did say.
Did I? Okay, I didn't hear you.
You did say.
I did not.
You did say that if I let you come on the show, you'd let me wear your wig for a week, and you have the nicest wig. And so let's talk about retraction of tissue, keeping it dry. Do you use a 0 cord and a 1 cord? Do you use a 2 cord technique, 0-1? Some people are using a diode laser, since when I came out of school, the first one was 50,000. Now they're down to 2,500. Do you if you did 100 fillings, how many of them did you use rubber band? Talk about the whole procedure.
Okay, now you kind of lost me. Are you talking about for a crown prep?
No, an MOD composite on a 6-year molar.
Okay.
Because that is the most common. The 4 6-year molars, when you look at insurance charge, take the 32 teeth. There's 4 big spikes on this 6-year molars. It's a tooth most likely to have an MOD, a root canal, a crown, an extraction, an implant. My God. It looks like, to me, it looks like at least a third of all the dollars that change hands have to do with that 6-year molar, which blows my mind that dentistry, pediatric dentists still want to put a sealant on a 6-year molar, some crappy sealant where you acid etching pits and fissures filled with Oreo cookies and Doritos, and you're trying to bond to an enamel. Dude, you're bonding to a graham cracker, and to drill that out and do an occlusal composite, or to take microabrasion and clean out. If you just take microabrasion and spray out the pit and fissures, you're in debt 100% of the time. But I just think the sealant should be replaced with a preventative resin restoration. And I think that if they're girls, make them tooth color, because they're all really into that peacock thing. Like ducks, like, one duck is the mallard's really pretty and the other one's just brown. And I think that boys, I think their sealant should be a preventative amalgam. I mean, just, it comes in, prep it out, do your amalgam, and I bet you that tooth nothing would happen till they were 40 years old. But that's a whole nother lecture. But yeah, so let's go to the 6-year molars and the MOD composite.
Okay, so you mean how I restore that?
Go through your technique. Do you use a rubber dam? Do you use cord retraction? Do you use a laser for tissue? Go through your whole technique.
MOD composite. First of all, yes. A lot of these are very deep subgingivally, and so you got that to deal with. And so I don't necessarily use a rubber dam, because sometimes you get these real deep subgingival composites, and the rubber dam for me just gets in the way. And I find with the greater curve matrix that you actually get very good isolation, because you got a circumferential matrix around the tooth. So I'll use some little dry aids, or some resorbent triangles in the buccal mucosa. Let's say we're working on 3. With the greater curve band, if one side of the prep is very deep and the other side is not so deep, you can actually trim the band on the cervical portion, allows the matrix to drop all the way down. And again, because the greater curve, when you tighten it, it pulls in very tight. So you usually get a very nice seal at the base of the prep. So now you got it sealed. I make my little contact openings, ready to go. So I would then just finish my composite like I normally would with your bonding agent. And you want to, I'd probably do an Activa base and then do a conventional hybrid on top of that. And then, the people always say, well, now you made an opening in the matrix. Now your contact is bonded to the adjacent tooth. And I say, yeah, that's true. That's fine. What you'll do then is you have to realize the bond is against a very smooth surface. And, the contacts, let's say the contacts maybe 1.5 millimeters wide and maybe 1 millimeter deep. So it's not a large surface. So I'll use a spatula, metal spatula, and you put it between the teeth and the matrix, and you torque it a little bit, and you tell your patient it's going to hear a little pop, because you're going to break that contact, that bonded contact. And in fact, it actually has a name. It's called a mopper pop. It's what Buddy Mopper came up with that term when he would pop contacts. And so you tell the patient, you hear a little pop, because they hear that and they think, oh, something broke, and just prepare them for it. And then to remove the matrix, I use hemostats, and you clamp the hemostat on the matrix, and you give it a little bit of a twist to pull the greater curve band laterally. And it just has to move just 0.5 millimeter, and it'll come right out. And sometimes you may have to put a Serisol, some kind of separating disc, not a separating disc, but I use a Serisol by Denmat. Looks like a little hacksaw, but it doesn't really take away composite and move it through the contact. But I have a very nice contact, because it was a direct contact that built the tooth in a neutral position. So I have a good contact, mesial and distal. And I did it without wedging. I was able to build in contours as needed. And so I didn't have all this complicated, expensive hardware that with the sectional matrix. One thing about the sectional matrix springs, they look good, but after a couple sterilization cycles, they start looking bad, and they lose their tension, and then your assistant usually ends up throwing those out, and you need to replace them because they're so small. So Again, you just need a top wire band or need a greater curve band on top of wire. Once in a while, I'll wedge it, not in the sense of I'm wedging in the traditional sense of separating teeth. I'm just simply placing the wedge there to hold the matrix up against the margin.
You mentioned the Sari Saw by Dr. Bob Ibsen at DenMat. I'm trying to think, who was that dentist that lectured all around the country for 40 years who loved the Sari Saw? He's from New York.
I don't know. I met the inventor at one time. Must have been him. So
was he a New York guy? New York?
I could say.
Oh my God! And when you come out with this, did you show it to Harold Burke, the founder of Pulp Dent Corporation?
What's that?
When you started your greater curve, did you go? You're using Activa. That was started by Pulp Dent. It was started by Dr. Harold Burke. Did you go show it to him? Did you try to get Bob Ibsen's feedback at DenMat? Dr. Harold Burke's feedback at Pulp Dent? Did you look at those kind of colleagues for help or feedback? Or
I just started doing it and putting it out there, and let dentists decide whether it works for them.
I love that necessity is the mother of all invention. And you're a doctor. You got 8 years of college. You already learned your math, physics, chemistry, biology. Running your own business, you just did it. I was just wondering if there was how the community of the existing people out there, of the dentists that had companies, if they were more if they were helpful, if they were friendly allies, or if it was competitive. I mean, when you go to some business worlds, like who's that guy, Kevin O'Leary on Shark Tank? He says, "My God, if my competitors were drowning, the first thing I do is stick a hose in their mouth." And I'm like, "Slow down, Spanky. I'm competitive, but I'm not sticking a hose in someone's mouth that's drowning." But I was just wondering if the other dentist-owned companies like Dan Fisher of Ultradent, Bob Ibsen, those guys came to your aid to help you along.
I never had any real contact with any of them.
Because they really reached out to me a lot when I started going, and when I started Dental Town, Bob Ibsen called me up and he goes, "I don't know you, and I hope you're smart." And he goes, "I'm looking at your advertising deal. I want to buy the inside front cover, the back cover, and the inside back. I've never even read the magazine. I just don't want this concept to fail." He goes, having a website community where all the dentists can go together and talk. Remember, this is 5 years before Facebook. He said, "This is so important. Here, I'll buy those 3 ads for a year. Send me the bill." He goes, "I don't want you to fail." So I was wondering if people who sell composites like Bob Ibsen or Dan Fisher's, like, these posterior composites and making tight contacts, this is such a pain in the butt. It'd be good for the whole industry if dentists could make their contacts faster, easier, higher quality, lower cost.
Yeah, I mean, that's my objective. But as far as hooking up with any of these other companies, nobody's ever approached me.
And Christopher Hitchens told a story about there was an atheist on his deathbed. It was his mentor. Hitchens was an atheist, but it was his mentor. And when he was on his deathbed, Catholic priests and everybody kept coming because they knew he was going to confess at the end because he didn't want to go to hell. And here you are, you just confessed on Dentistry Uncensored that you don't use a rubber dam. So I'm thinking at least, 80% of all the townies, they already know you're going to hell. So are you going to be the chief dentist in charge of hell? Is that your goal? Talk about that, because is it extremism? Because we go through all this stuff where, when they told me I had to practice under rubber dam the rest of my life, the first thing I did is think, well, that's easy. I just went in my operatory and I tacked a rubber dam right to the ceiling. And I thought, damn, check, done that. I'll always practice under rubber dam. But then you had those mouth, the ice lights come out. You got, there's all kinds of different assistants, but you have an assistant that can retract the tongue. So talk about rubber dam, because it is... it's not a venial sin. It's a mortal sin. All people who do bonding posterior without a rubber dam, I'm pretty sure, are going to go to hell due to the comments that you see on social media. So talk about the rubber dam, because don't you agree it's taboo? I mean, and a lot of dentists, I guarantee if they were 30 years old, they don't have the guts to go on social media and say, I did this without a rubber dam.
All right. I do most of my dentistry without a rubber dam.
Gosh.
So that's out there. Because I can get the isolation I need. I mean, now if I couldn't get the isolation, rubber dam goes on there, but I just don't see it's necessary. Now, I have my own version of isolation. It's available on Dental Town. It's called a saliva injector. Saliva injector holder. I work with that, and I use the Neo Dries. And actually, I use the Neo Dry on the lingual side with my saliva injector holder. And I have my greater curve matrix, which is circumferential seal around the tooth. And so I have no problem keeping saliva out of my preps. Now, and one thing I had one time, or once in a while with a rubber dam, is, unfortunately, saliva and bonding agent kind of look alike. So once in a while, you have a little bit of leakage underneath the rubber dam, and you're going, is that saliva? Is that bonding agent? Well, I don't have that problem because I don't use a rubber dam. I can tell if I'm getting leakage. So I find I can do great dentistry without using a rubber dam. And this is the way I am.
Do you feel, you put an online CE course on, and in the middle of the pandemic, you did that on 6/25, just 3 months ago. Do you feel, talk about that course, and do you think people listening to you right now would have, the objectives are accomplish excellent isolation. Do you think they would really learn everything you're talking about right now if they watch that course?
I introduced my saliva injector holder in that course. And I show one case where the patient had this very bulbous tongue, and he was overweight, he had very thick buccal mucosa. And with the Neo Dries and using my saliva injector holder, I was able to do a crown on a second molar, a lower second molar. And I had great isolation. In fact, I use it when I seeded the crown. So in that course, you'll see how I use that saliva injector holder.
Okay, I can't believe we went over an hour, and you have an online CE course where they could get, very well done, very well reviewed. Everyone loves it. Since you've already admitted you're going to hell anyway, and by the way, do you have a roommate? If you're looking for a roommate, I remember in dental school, UMKC had this, I'm looking for a roommate list, and I put my name on that, and George Rui called me up, and it worked out perfectly. Have you signed on a list for a roommate or anything? Do you know? In hell? Because you did something else. If you weren't going to hell the first time, you sold to a DSO, right? You sold your office to Cincinnati Dental Services with Dr. Larry S. Frost. Talk about that. What was that like? How many offices does Cincinnati Dental Services have? How many are they up to?
I don't know. It's less than 10. I think they have maybe 8. I couldn't tell you. I work out with one of them exclusively. For me, that's been a great experience. I was somewhat reluctant, because I had control. But this worked out beautifully just because I said, I want to be able to do photography, or I want to do video. And they said, fine, do it. I said, I want to use certain materials, and I want to have control of my treatment plans. They said, fine. And they have never said a word about how I want to do my dentistry. So it was the best of both worlds. I could just be a dentist all day and play dentist all day and not have to worry about all the other stuff. So for me, selling my practice to joining up with Cincinnati Dental Services worked out beautifully.
So you're right. They do 2, 4, 6, 8. Who do we appreciate? They have 8 offices around Cincinnati, and this is what I've been telling everybody that. I don't like the term DSOs because it includes, a guy with like Larry with 8 offices, with a guy like Bob Fontana who's got 800, and so much of the it's so difficult to wear all those hats in dentistry that you got to start limiting. If you're going to learn Invisalign, when anybody tells me they're going to learn something, I always say, okay, well, what are you going to give up? Because don't tell me you're going to master placing implants and endo and Invisalign. You can't do everything. And when you just have one layer, Then you can bring in full-time people for just HR, accounting, bookkeeping, marketing. It's just easier. They just do better. They can take advantage of very low cost advertising on radio and TV that's been decimated. The prices on radio, oh my God. When I got out of school, I couldn't believe people pay that for a radio commercial. Now you can buy an hour for $100 in Phoenix. So one layer, one flat. I don't care how big they get if they stay flat, but having a second layer, I just don't see. I have not seen how it works, and obviously Wall Street hasn't seen how it works because none of them are publicly traded. So you're just working for one family. Are you retired now, or are you going to go back? Or
I'm gonna go back.
You're going to go back?
I think once this COVID thing all kind of, we get our vaccine, I intend to go back. I was down to 1 day a week, which was just perfect. They were comfortable with it, so I intend to go back and start again. If I ever am full time.
But are you staying out now because you're kind of want to avoid the coronavirus?
Yeah, I'm 73, and I think I'm healthy enough. I go back, but Jennifer, my wife, says you're not going in there yet. So when she gives me the go ahead, I'm in. So
what are you still doing for Jennifer? How come Jennifer wants you alive and not dead with the insurance premium? Is that who you're looking at right now?
Yeah.
Tell her to come to the screen as a witness. I'm calling a witness. Tell Jennifer to come behind in front of the camera and tell us why she still wants you to stay alive. It sounds like you're underinsured. Have you told your life insurance broker I don't have enough insurance because my wife still wants me to be alive? But do you feel but that DSO, they're running 8 offices. Do you feel that it's that like you're at home? I mean that you treat other people like you want to be treated?
I tend to go back. I really enjoyed it. I still it's nice. I go in to do dentistry because I want to, not because I have to. And so that's just great. And again, I can do dentistry. I can play dentist all day. I don't have to worry about all the other stuff involved with the practice. So that's why it's worked out so well for me.
And how old's Larry now? Larry Foss, the founder of Cincinnati Dental Services.
I guess he's my age. I don't know.
73. And do you think he's going to stay a very large group practice aide, or do you think he has ambitions to go, bigger? Do you think he has an exit strategy where one day he's going to sell it to a larger DSO?
Well, I think right now they're part of American Dental Partners as it is. So
okay, that's what I did not know. So he sold to American Dental Partners?
It is, I don't know what that relationship is.
But he's with American Dental Partners?
Right.
Because that's the game in DSOs. Their exit strategy is they don't go public on NASDAQ like Snapchat can. They just they'll the first time they'll play with somebody who'll throw in 5 to 10 million. And then their exit strategy is someone does, 10 to 100 million, and then their exit strategy is someone does 100. It just keeps giving it to bigger fish. That's what's going on now. But you're happy there.
I'm happy there because they still I can still be independent how I want to do my dentistry. If that changes, then I'm out of there. I don't need to be there. But right now, it's just a great relationship, and the hygienists they have in the organization are just wonderful. They really care and they do great work. So everybody really strives to do the best they can.
That is awesome. And so final words, will you give final words to the graduating class of COVID 2020? They just graduated 3 months ago. My gosh, last year at this time, there would have been 5,000 help wanted ads on Dental Town for associates with 1,000 practices for sale. Now there's 2,000 guys selling their offices and only 1,000 jobs out there. And it's all DSOs. Like Cincinnati Dental Service has 8 offices. Then now they, sounds like they sold to American Dental Partners. What advice would you give? And that's why I love the DSOs. They're the only ones employing my new homie replacements that just got out of dental kindergarten school. But what advice would you give to these young kids that $400,000 in debt, they're underemployed? They're in the middle of a pandemic. What would you say to them?
Gosh. I don't know. Yeah, it's hard for me to give advice to them in that regard because I never was in that position. So, I could just say, keep your integrity. Just keep your integrity and do the best dentistry you can and educate yourself. Just keep being and beyond Dental Town. I mean, it's a wealth of information. Whatever you have a question about, you can go on Dental Town, do a search, and you're gonna find an answer. And so just constantly educate yourself, get better and really get better at the basics. Place wonderful composite restorations that hold up and do well. Get good at extractions because that's always going to be there. And so and like I said, just be good at the basics. Get good at some basic perio. So have that basic there, and then once you have that foundation and you want to move out on your own, fine. Then you can start specializing maybe in implants. I think a general dentist who does his own implants, I think would be a good place to go. So that would be my advice.
You didn't mention endo, getting people out of pain.
Well, I think, endo, yeah, be good at endo. I mean, with all the instruments and the different techniques and armamentarium that's available in endo, a general dentist can do really good endo. When you talk about more endos, I get a little bit, because I think, when it comes to more endos, I think really a good endodontist needs to have a CT, machine, because there's so many hidden canals and so easy to miss them. But I think, from bicuspids forward, I think a general dentist can do beautiful endo.
Well, let's talk about that, because we know that if an endodontist does a molar root canal in 5 years, 5% are extracted. And if a general dentist like you and me does it, it's 10%. You have scale in group practice. Do you have does Cincinnati Dental Services have a full-time endodontist that goes into the location to do the endo, or do you have to refer?
At this point, we have to refer. I believe they're looking for one, but again, since I haven't been out of the office for 6 months, I can't say.
So, but when you were there, when you left, did they have any specialists rotate in the office?
They had a periodontist who was very good.
He placed implants and did perio.
She placed implants and did perio.
Yeah. So let me just finalize with one little detail there. So what the DSOs are seeing is they get kids in, they graduate, they teach them how to place implants, and then 2-3 years later they're gone in somewhere else. And then on implants, if you do 5 implants and one of them fails, it takes the profit dollars from the first 4 to replace the 5th. So there's no money in the game. If you're not, unless you're redoing your own failed implant for free, where you're free labor, and then it still costs your opportunity time, but you obviously have opportunity time, the opportunity cost. But the DSOs, they want endodontists doing all molars, and they want oral surgeons or periodontists to place all implants, because you're not going to grow a scalable, profitable DSO by having general dentists, especially the young ones, the first 5 years out of school. Holy moly. If they place 10 implants for you before they change jobs every year. Millennials do, from hair to fang stocks. But if they place 10 implants in and do 100 molar endos for you, you will not make any money if you stand behind your work, warranty everything. We've always warranted everything 5 years. So that's kind of the future. But hey, buddy, between me and you, your product massively helped me. It was so awesome when that came out. I mean, my gosh, I loved it. I still love it. You've done so much for dentistry, and the time you've spent posting 1,800 cases. I mean, you're just so selfless. You're just a hell of a guy. I truly love you. I respect you. And I'm sorry that you're going to go to hell when you die.
Well, Meet you there, I guess. But,
All right, and when you get there, if you need a roommate, just go to the sign-up sheet and write your name, and I'll be rooming with you. So have a great, wonderful pandemic, and I'll see you on the message boards.
well, that'd be fine. I just want to let people know, if they wanted to call the office, it's 866-4-wedges. But you might say, well, how do I get a phone number with 4 wedges? It's 866-493-3437, which is 866-4-wedges. At one time I had a car.
Numeral 4, then wedges, WE.
866-4-wedges. You might wonder why I have that, because I'm sort of anti-wedge because it's not needed. But I had a carvable wedge at one time, it went nowhere. So I still had the phone number, so I kept it. So that's how we got 866-4-wedges. And anybody wants to, I'm happy to answer questions. I do it all.
So what's the number without the 4 wedges? 866 what?
493-3437.
493
3437.
3437 spells 866-4-wedges.
You betcha.
Wow. Okay. Well,
and then if they want to email me, it's info, just a generic info at Greater Curve. Always happy to reply. I mean, I spend a lot of time on the phone with dentists. So anybody want to speak to me personally, has any questions, not a problem.
so if they want to talk to you personally, it's 866-4-wedges. And the 9 is a W. You're very good. Well, hey, Dennis, thank you so much for coming on the show. You definitely left the playground of dentistry better than you found it. Thank you for doing so much for dentistry, and have a rocking hot day.
Thank you very much, Howard. Thank you. You have a good day as well. Thank you.